Well, good afternoon, and I was convinced I'd paid more people to come to this session than this, but maybe they'll fill up in a minute. A warm welcome to you. I'm Ian Barton. I'm the founder of Health for Development, and those of you who've been to things that I do at these sort of events will know my technique is usually entirely selfish, hence why I'm not actually facing you, I'm facing the two big guests that I've got with me today, because we're all here to learn, right? This is not us talking to you and telling you, it's all of us learning from each other. And today I'm really, really pleased to be joined by two wonderfully informed and smart people in this space and in this subject matter. Saartjie Grobbelaar is the Professor of Innovation and Inclusive Development in Industrial Engineering at Stellenbosch University. And then Tiwonge Mkandawire, we've been friends for many years, and Tiwonge is now the Director for Supply Chain at Village Reach. You spent probably equivalent time, Sarah, in management consulting and academics, didn't you?
Well, until 5 years ago, yes.
Yeah.
But I'm starting to become a career academic now.
A career academic.
Yes,
now.
I returned to academia. Well, I was in consulting for about 6-7 years. And then in 2012, after I was very lucky to be able to do a master's at Cambridge University, I came back and joined the university sector again. And in 2015, I joined the Department of Industrial Engineering.
And Tiwonge, a Broadreach, MSH, a USAID, now Village Reach. I was telling somebody this earlier today. They said, gosh, she jumps around a bit. I said, no, it was about 5 years at each one. So you must have started at 12. Yeah?
No, it was more like 10.
A master's in pharmacy. So a pharmacist who then did her MSc in pharmacy. And then also an MPH from the University of Cape Town. Yeah. But did you know, when I was stalking you both on social media to do my preparation, you both worked at Frost & Sullivan.
Oh, really?
There you go.
I saw that on your notes earlier, so I'm not surprised that you said it.
Oh, that's fantastic. We must chat about that. It was an interesting time at Frost & Sullivan.
It was.
So what we're here today to talk about is this: what did we learn in the last 2 years? This has been one of the most incredible events of any of our lives. And what did it teach us? What did we actually get out of it? Many have indicated just how much COVID has slowed down the movement of goods and how supply chains are faltering around the world. But there's those who are also aware of all the accelerated improvements that have taken place and that have arisen as a result of those disruptions. You put human genetics under stress, they excel. And so we've seen a level of long-term resilience and efficiencies which hopefully are going to benefit our markets for a long time to come. The pandemic has certainly increased the importance of supply chain as a strategic lever for several industries, and it's also led to the reconfiguration of value chains across the world and strongly in favor of recovery and resilience. It has exposed faults in the modern global value chain like never before, and it's uncovered failings in international supply chains and very specifically of healthcare equipment and medicines. If you rewind the tape, it's only 2 and a wee bit years ago that we were back in March 2020, and we all started to hear about this thing and to understand what the implication might start to look like. And I remember when the first lockdown was announced in South Africa, I had friends from all over the place phoning me up because they would assume that I would know what was going on, and saying, do you think he's going to extend it beyond 3 weeks? Yeah, remember? Fast forward a little bit, and last year I was busy filling in my tax return and doing my logbook. And in that tax year, we spent 9 months unable to actually do anything of economic viability. And so we all went through this first big pivot. We all in our businesses, in our lives, had to reshape the way in which we thought about the way in which we did work, the way in which we engaged, the way in which we actually conducted our day-to-day lives. And so I refer to that as the first big pivot. And I remember when I was talking to the staff, it was when I was still at Chai, and I was talking to the staff around the world. And that was also a really cool thing to see. For the first time, certainly, that I'm aware of, we responded as a species. When it was us against them, it was Homo sapiens against the bug. And we all pulled together. Normally when it's us and them, it's along different lines of fracture to what we saw in the pandemic. And so when we were talking to the staff at that stage, I kept saying to them, there's three things you've got to think about. You've got to think about how to respond, because we must respond, and we must respond aggressively in order to manage what we were dealing with. But the second was that we must protect the core. We must protect the work that we were doing before this thing happened and make sure that we stayed in the game. And because, especially in public health, what we were doing was pretty important stuff. And so we had to make sure that that kept going. But then there was the third point, and the third point was, how do we use this as an opportunity, and how do we actually leverage the money that's going to get spent, the attention that's going to create, the education among patients, the awareness of public health and the importance of public health? How do we use that opportunity for good? And that eventually became this catchphrase of build back better, but it was really, in those days we were talking about no crisis should be allowed to go unutilized. Yeah? No crisis should ever be wasted. So off we went, and there's been all sorts of parameters and things that have been measured. I've got one fun one for you today that I want to show you, and that's the little graph up on the top right corner here on our screen. Does anyone want to take a guess what that is? You can see there's a dip just at the beginning of 2020, and then a consistent climb thereafter up to just recently. Anyone want to take a guess what that is? It's the Maersk share price. It's exactly what it is. That is the share price of Maersk shipping lines, which went flat, 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 flat. The pandemic hit, there was a little bit of a dip, and off it went. 5-fold growth in their share price in the 24 months of the pandemic. So that's just a really interesting contra-angle to what this thing has done in supply chain. There's been lots of negative, but for some people, there's been an awful lot of positive. And when you look at this data, the data that's coming out of the surveys that are happening, some really interesting points in healthcare specifically. Increasing of inventory. Did you ever think we would talk about putting more inventory into countries? 61% of supply chain folks are saying that that's what they're doing. Not only putting more into the supply chain, but distributing it along the supply chain. So creating buffers of stock within the supply structure. And then regionalizing, moving to a regionalization of strategy, nearshoring and increasing their supplier base, but more importantly, nearshoring production, nearshoring the actual making of goods. And for any of you who were involved in those nights of trying to figure out where we were going to get the next shipment of masks from back in the second quarter of 2020, you'll know that nearshoring became a very, very important part of the response. So that shows you that people have already started to change their business focus and change the way they think. And that brings us to a really important part, which is pivot 2, the second great pivot of the pandemic. We pivoted into the pandemic. Now we have to pivot out of the pandemic. What are we going to do with the lessons learned? What are we going to do with the capacity created? What are we going to do with all this attention and awareness that has been developed within the communities that we work with in health systems? And so that's how we're going to kick it off, is to hear from both of you. In terms of your thoughts, where do you think we went right? Not just concentrating on, it's easy to get into the where do we think we went wrong. Where do you think we went right in that first pivot, in that responsive pivot? And then, what are you thinking that people need to be contemplating in the second pivot of utilizing the pace of the ball, utilizing the opportunities that have been created? You want to go first, Tiwonge?
Sure. I think the point that you made, that right at the beginning, it became about Homo sapiens against the bug. I think that's something that was very true in the global health space specifically. In the global health space, we've got a lot of donor-funded organizations working with governments, private sector entities to get things done. We've been doing it for years. But we haven't always been together about it. We still compete. At the end of the day, we all need to survive, right? But I think that is one thing we got right. When the pandemic hit, we knew that it was going to hit the health system hard. I don't think we actually had that lull of, oh no, it got quiet and there wasn't much to do. It was immediately, oh my goodness, this avalanche is coming. We need to do something, and we need to do it together. Otherwise, we're all going to fall flat. And I think as as local organizations, regional organizations, international donors, governments, the fact that people and entities were willing for the first time in a very long time to put the barriers aside and focus on let's get vaccines to the people. Let's figure out how we're going to take care of those that are affected, even though we don't yet know how to do it in the early stages. And I think that's something that has allowed, and it has evolved over time, it has allowed us to just be a little bit more open to sharing data, to piece together the visibility that we could with what we had in our different silos that we weren't sharing before. So coming together, sharing it, create the visibility, share the data, get the products in. Yes, there have been failures, but that for me was one of the biggest things, collaborating, radical collaboration in the global health space.
Radical collaboration, that really, it was radical, wasn't it? Because nobody was allowed to say no. Nobody was allowed to not collaborate because you didn't want to be that person, yeah? And so it created a level of collaboration that was completely different and therefore a speed that took place. I'm always reminded in these conversations about what happened in that phase, about that great book, The Speed of Trust, right? And that was kind of what it did, is we all had to actually just trust that we were going to win this thing.
Exactly.
And therefore, we moved at a rate that was completely different to anything we'd done before. Yeah.
Absolutely. I mean, I was looking at David, who was in the session before. I mean, him and his team got together and developed the logistics management information systems that's being used in about a couple of countries, a little over 10. And they developed the module that we needed to track the COVID vaccine. They got together, did that in 4 weeks, and got it out in a public health setting in sub-Saharan Africa. I don't think there are many programs that can actually come back and say, oh, no, we did that and it's working. 4 weeks. It was on the ground.
Yeah, and I think from a personal perspective, I was sitting at home and everybody thought, let's do something, let's help. And I think there were so many people building ventilators in their garages. So we decided, and our university also wanted to build a ventilator. It was, in the initial few weeks, that was a very big focus. And we started to also think as, academic or innovation system scholar, what can my contribution be? And we started to develop a few guidelines on responsible innovation. So I think it hasn't necessarily been used as much because the larger companies took over, the big initiatives that could scale, that could get vaccines to people were the more important ones. But what I thought was really interesting is, citizen science, citizen processes could also potentially in the future be something that's more important in the healthcare context. The role of lead users, the role of a broader range of actors that can participate in an innovation system. So I think it's something that I can see has some potential, but of course it's a highly regulated environment, so it's not something that is going to be so easy to do and look at further, but there's definitely an area of work that we look at in our program.
Did you just use the term citizen science?
Well, that is when people look for planets and things and they go and gather data on behalf of scientists. But it can also be a process where people try technologies, build it on their own. For instance, there's a huge initiative around people who are diabetics. It's so difficult to develop the devices. So lead users have started to develop their own solutions where they've got patches and then where they can administer insulin. So there's a whole range of new innovation actors that I think can, in future, I'm not sure in what areas necessarily, can also be integrated in innovation systems. So what we try to look at is how do we create more inclusive innovation systems where we can expand the process, not only of delivering, but creating these solutions that are really useful and relevant, and also for neglected groups where it could be completely overregulated.
It's almost like the garagiste of medical devices. No, that's actually really fascinating because we met all sorts of people in that first phase who were standing up and saying, I'm going to have a try. I'm going to have a crack at this because it might become useful. You've also, when the vaccines eventually came, is Bridget. The day that it was announced at -20, my heart sank, I got to tell you, because I knew what cold chain capacity we had on the continent and how little capacity we had to do deep frozen. But you've seen some incredible stuff going on in cold chain specifically, and some really, really great innovation happening there.
Yeah, and I can again speak from my own perspective and experience. I think one of the important things when this kind of event happens is that something comes onto the agenda. There's all of a sudden political will, and that also pushes the availability of grants and funding for people to develop new solutions. So we've recently been awarded a grant. It was given by the Flemish government, and an organisation called the Impact Licensing Initiative scans the private sector for technologies, and then they license these technologies for developmental purposes, and that is then we can use this IP free of charge. Now, this kind of project has been in the pipeline for many years, but all of a sudden there's political will to look at these things again. So this creates an opportunity for a collaborative program between Stellenbosch University, the Impact Licensing Initiative, to test a cold chain technology that's a passive cold chain technology that can provide cooling for up to 3 weeks. So the company's cooling boxes are the size of this room with a thermostatic battery. That's the specific IP element, but we're going to miniaturize that and see if we can create cooling technologies for the last mile. But it will be fitted with IoT, so you can have visibility. And the moment we can have visibility on where these boxes go, there's a smart lock, we can track the temperature, new funding models become possible. So now we can say, okay, we're not going to give lots of vaccines to a country. The way that we're going to fund this is that we're going to fund vaccines applied to arms. So it's an outcome-based delivery model. And around this is how do we create localization? How do we create jobs and sustainable delivery models? So attached with this, we look at a social franchising model. So I'm not sure if you know about the Johnny Clinics. That's one example of a franchising model. But inclusive innovation means that we need to use technologies for improving access to healthcare, but we can do it through the mainstream economy. And that is one example where I think there's been a shift and interest again in looking at these very old problems that was also presented in the previous section or session.
I promise I didn't pay her to say anything about Njani.
Well, we work with Njani and it's a wonderful experience.
So, looking at that as a logic, one of the big opportunities that I saw as lived through was this willingness of the healthcare professionals to accept that not only were patients actually quite capable of self-diagnostics, self-decision-making, and even self-treatment, but that nurse practitioners, community health workers, community pharmacists were very, very capable people within a healthcare system. Have we seen as much of that in other parts of the continent? I mean, Village Reach works all over the continent, well, multiple countries on the continent. Mm-hmm. Have we seen as much acceptance of the need for transferring the responsibility for care not only into other healthcare professionals, but down to self-care as well?
To a certain extent, I'd say we have. I think, what you were saying earlier about because there was this need, there was a lot of doors that opened, grants were coming through. So yes, the money was coming in, but because there was a big problem that governments were grappling to deal with, and I mean, we work predominantly Mozambique, Malawi, DRC, Tanzania, Cote d'Ivoire, and Tanzania. And I think in as much as there was that openness to shift certain things, not only in terms of the human resources that we're using. So yes, definitely, community healthcare workers. On this continent, maybe not so much for South Africa, but 40% of the people on this continent live more than 20 kilometers away from the nearest public health facility. So it's either they're going to walk or get on a bike or something to get to the health facility, or you send a community healthcare worker to them with whatever that they need. And during the lockdowns, most people were too scared to come to the health facilities. Oh, I'm going to get COVID, I'm going to die. But the CHWs were still going out there. And in most countries, CHWs are still not recognized as part of the health system. But during this pandemic, they were going out there. They were the ones that were, taking the messaging, raising demand for vaccines. And so to a certain extent, yes, there was that openness and recognition that they play a role. But beyond that, there are lots of innovations that we've been testing and trying to get work as part of an integrated health supply chain for a while. Drones, for instance, for us in Village Reach, we've been implementing that in the DRC, in Malawi for a couple of years, for lab samples, for a couple of medicines. And because those investments had been made before, we could actually use that to move vaccines to places that were really hard to reach. And they were being more received by by governments, by the organizations that we work with, because now it was like, hey, let's use whatever that we have in our toolkit to actually get this product down there. So I think for me, that openness is something that we really need to make sure that we harness and we don't lose out on, because there's been so many of those innovations. Here in South Africa, we're having a conversation with a colleague earlier that, to a certain extent, and some might argue this, but the way in which the vaccines were procured, distributed, gotten into people's arms using public, private sector service providers, to a certain extent, was a glimpse of how maybe your NHI system could work. I know it's got a long way to go, but the whole basis of it is provide services through whatever platform you've got, whether it's public, whether it's private, get the commodities there, get the service provided there, get the job done. Yes, it might cost more. Yes, there are issues with the supply chain. Yes, there are issues with demand and everything else. But you got people's, doses done using both delivery platforms. So what are we using? What are we learning from that and taking forward? What was the good that came out of that we need to make sure we don't lose out on? So I think we did see that in a lot of the countries outside of South Africa as well. But the question still goes back to, are we harnessing it enough? Are we reflecting enough, documenting those lessons enough, and embedding them into policy, into the way we do business normally?
It's amazing how your agenda changes in these conversations as it goes along. It's really quite superb. You went to demand generation. Okay, and those of you who've been with us in the public health thing over the last couple of days, yesterday will have heard me going on and on about this, of how I think it's the piece that we miss so often in public health programs, and that's my health for development demand diamond at the bottom. It's just demonstrating how fundamental demand generation is in a successful access program. But if we go to there, if we actually go to how it got done and what you need to create for proper demand generation, we quite quickly get to the conversation around advocacy, right? Absolutely. And how we have to actually drive awareness and drive the political will, as it were, in order to get the right messaging out there and to get the right energy behind things. I'd never heard about the policy window logic and policy window theory, and so I think you need to give us a little bit of an explanation. Give us the 5-minute lecture, Professor.
Wow, if I know that much. Yeah, so in a previous life, I was actually working for 3 years in a social sciences department. And we worked on a program to build capacity for African universities that their research can have impact. And a big part of the work was, how do we look at policy impact from research? And yeah, I'm an engineer, so I'm not necessarily a political scientist, but there are some incredibly useful frameworks to help us understand why and when do politicians sometimes become really interested in a topic. What has to happen, and why? How can we leverage this? Well, they leverage it, don't make a mistake. Politicians will never let a good crisis go to waste, but I think implementation people and academics need to understand this as well. So the policy windows idea was developed by King Din, not M, D, with an N. I've miscited him many times, in 1993. And it's actually a very simple but very interesting idea. So basically, there are three streams. There would be politics, problems, and solutions. So politics is when maybe there's a new government, or like in 1994, huge opportunity for new policy suggestions.
Or a new global AIDS coordinator.
Yeah, or a new president or something happens. And then there are problems. So COVID, very good example of a very big catastrophe. The politicians actually, I think our president used it very well to raise his profile as a strong leader who is doing much better than any of the other countries were doing at the stage. And then, of course, there are solutions. So when any two of these streams come into play, one can say a policy window is opening. But then, how are we ready for this? And that is where capacity building comes in. Who are the people who had the most impact in this time? It's people who are already working on viruses, who can identify the Omicron virus as a new strain. It's not people who now all of a sudden become interested in building a ventilator in their garage. It is the people who already have institutionalized capacity to respond to these issues. And I think that is very important because as industry people, as researchers, we need to make sure that the capacity is there and maintained so that when there's an opportunity to pivot into another area where there is support necessary, that we can immediately react to it. And that's also how you create opportunities for yourself, of course, to be the person who is ready for this. And there are quite a few other frameworks that we also looked at, like coalition frameworks, where typically when there's now this new policy environment or a policy question problem, there are different coalitions around how should we address the problem. So there are fundamental agreement between the groups usually, like would we want a market economy or a centralized economy? Let's say we speak about how we set up an economic system. But then how are we going to implement it? There's usually the debate within the coalitions. And the same can be happening also in our context, where there are different approaches and beliefs of how to address that.
So we had this huge opportunity window, this policy window that opened up in the crisis. Where do you think it is? Do you think it's still there? Do you think we've still got this huge tunnel that we can drive policy shifts through, or do you think we're starting to see it shift? Tiwonge?
I think I've asked a couple of people this week whether we haven't missed that window, I think there were a lot of shifts and opportunities that were, a lot of initiatives that were driven because we were in a pandemic. But I feel like in as much as we're still dealing with COVID, it's kind of become normal. I mean, most of us have put away our masks. We're getting comfortable. We're moving on to the next big thing. I mean, in some of the countries where we're working, they're starting to see cases of wild polio, which we haven't seen in years, and we're supposed to be eradicating polio next year. And that all of a sudden is at the top of the agenda. Are our systems actually picking up cases? The agenda is pivoting. A lot of the countries have lifted their states of emergency and things like that were enabling a lot of the innovations and solutions to be implemented. So personally, I fear that we have missed the widest part of the window, if you want to call it that. Having said that, and if we look at the history, and once again here in South Africa, with HIV, for instance, there was a time when, remember the days of stop stockouts? Remember those days? They'd be calling health facilities and finding out about stockouts, and then it would all go into the news, and government would usually be scrambling to answer. But that led to, hey, let's improve the public health supply chain visibility, and stock visibility system got in there, and data is being collected and made available. And now they can actually answer questions about what's going on in the health facilities. So I still think that the COVID pandemic highlighted a lot of fractures in the public health space when it comes to data sharing. It's made us question ourselves about our understanding of our clients' needs. I mean, part of the reason why we haven't been able to, right-size the balance between supply and demand is because we don't fully understand what it is that our clients want, their true fears. We've learned a lot about using social listening to figure out what their issues are, where those hotspots are, where those kind of issues are, so we can target messaging. And those things we can be pushing into implementation going forward. But there are bigger shifts, I think, that could have happened under the opportunity that we had, like, solidifying some of the governance structures to enable continued public-private working together that I fear we might have missed the window a little bit in certain geographies.
I'm watching the clock down there, and there's some people in here who I'd really like to hear if they've got questions. So thank you both very, very much. But the areas of concern, as you say, we haven't used this crisis as well as we could. We haven't done enough yet, and we have to keep pushing hard. Vaccine inequity is an obvious one. 8 out of 10 people in the developed countries of the world have had at least one dose of vaccine, and yet only 1 in 10 in low-income countries have had access to vaccine. With the massive shortage of personnel in our supply structures, we've got this significant issue of shortage of containers in the system at the moment. But then we've also seen this generation worth of innovation and transformation that's taken place in just 30 months. But even with that, we've still got huge talent gaps that exist that we've got to figure out how to address. We've got to look, we haven't achieved end-to-end transparency in these supply structures, even in vaccine management, and we certainly haven't got to where we have in any way addressed the need for localization of resilient and sustainable production capacity. And we also just need to apply our minds to the phase of economic cycle in which we find ourselves. Is that as this, we've been flavor of the time because of the pandemic and public health, and as we move into this cycle of constriction of financial resource availability, we really, really need to be applying ourselves with energy and with focus to the things that are going to make a difference for patients that we serve. So, thank you both very much. Thank you very much. What questions do we have?
Anybody?
One at the back.
Oh, there's one. I have one while I walk there. Vaccine hesitancy. Why are we sending back or expiring some of our vaccines if, what is it that we did wrong in that regard?
Shall I go first?
Go ahead. I'll go after you.
Many of you have heard this lecture already. I promise not to bang the lectern too hard. Part of the problem we've got is that the people that we have designing the demand generation systems for our public health programs are old white doctors sitting in rooms, the same doctors who 36 months ago couldn't spell PCR. There's really a need for us to change the way in which we think about demand generation, the people we make responsible for demand generation, and the way in which we then message that out to the public at large. We have allowed the conspiracy theorists to own the space for the last 18 months, and we only have ourselves to blame.
Can I just answer? Okay, so I think there is that, but then particularly for broader Africa, I think our infrastructure when it comes to data and understanding our health systems has been very much focused on supply. Let's make sure we know where our commodities are, how our services are working. We haven't invested enough in understanding our clients and understanding the clients right where they are, because it's hard to get to them. In most countries, we can say, oh no, we'll check social media, we'll do social listening, we can do that to a certain extent. But a large portion of the population might not necessarily be active. So it's very hard to fully identify what the real concerns are when it comes to COVID. And remember, COVID is a relatively new condition, how many years has it been? 2 years, odd. If you talk diabetes, there's a whole lot of information out there. So we had 2 years to learn about the condition, to learn about our clients' fears, and find a way to communicate it. So that's an area that I think is still evolving, and that's part of why the vaccine hesitancy is still a big issue.
Thank you. Interesting debate. I would like to have some comments about the response of the private sector in actually shifting some production line to respond to the COVID and the massive importation from China. Yeah, I'd like to hear a little bit about can we consider that as something that went well during this pandemic? How can we learn and what can we learn from that? Thanks.
So I think in what we have experienced, it touched on a couple of things. When it comes to vaccine supply, it wasn't such a massive issue. Yes, in the early stages, yes, but no. When it comes to everything else, PPE as an example, I think it made us all realize, and I don't think that's something that was unique to health. I don't think it was unique to just PPE, that the fact that we are so reliant on certain geographies to manufacture the bulk of what we need, in as much as yes, it is more cost effective in a lot of ways, it does present challenges when you're looking at global security of supply, particularly for very important, very critical life-saving commodities. We ran a program, so we work with community healthcare workers. We believe you need to get them supplied so that they can supply those that are really hard to reach, but to do that, they had to be protected. They needed PPE. So we were buying PPE for these CHWs, but for a long time, we couldn't get it in for various reasons. One of them was because for a long time, most of the containers were stuck here and, or on the other side, and there just weren't enough containers to move product. The other side of it was, one, there was too much demand, and there was not enough supply here on the continent to actually be able to meet that demand. So I think it raised a lot of questions about whether we do need to be paying a little bit more attention to the conversations that have been going on in corridors for donkey years about regionalizing. I'm not a big fan of localizing, just to put it out there, particularly for this continent, because I don't think it's very sustainable. I don't think a lot of the markets are big enough to sustain localizing. However, maybe there's more that needs to be done now to figure out how we shift the way in which, especially in health, that governments and agencies that buy, how they buy, so that you can actually, either pool the volumes to be able to garner the kind of a voice or demand for products, so that one, we're getting prioritized, but two, in the longer run, maybe then there's enough market to justify a regionalized market manufacturing capacity. I think it's something that needs to be approached very carefully, because otherwise you end up with white elephants that, yes, the manufacturing capacity is not really able to continue for a long time. But if you can sort out the procurement agencies, figure out how to pool the procurement for the volumes that are on this continent, and then channel that towards existing suppliers for now, and then hopefully contribute to a regionalized approach for manufacturing, I think that's a more sustainable approach.